evening with endoscopy experts webinar. It is a Kasoga Endoscopy Committee webinar. So I request usually our webinar start with a prayer song. So I request Mr. Arun to start the prayer song.
धनसम्पदः शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्नमोऽस्तु ते शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः
Thank you, Mr. Arun. I would like to invite Shobha Gudi Madam to welcome our today's faculties and the chairperson.
Yeah. Am I audible?
Yes, ma'am, you are audible.
Yeah, somehow my video is frozen. I don't know. I think I'll switch the video off. It may be better. So, a hearty welcome from Kasoga to all the audience who have joined, and to the viewers, of course, not audience, and also to the faculty. And Kasoga is indeed proud that endoscopy committee is performing so extremely well. And already the 10th webinar today. Prabha, you have done amazing work, and you have got a very vibrant team with you. We can see that. And congratulations on bringing 3 faculty for one topic. Very focused way you are going ahead. Very focused. I mean, the skill transfer is best when you deal with one subject in this detailed way. And I think that is a real intelligent thing to do. So all the very best, and over to our president, Dr. Durgadas Ranna. Thank you for calling me.
Thank you, ma'am.
Good evening, everybody.
Yeah.
Shall I?
Yes, sir. Please, Dr. Asrena, sir, our president Kasoga, who is main backbone for everybody, and he is always encouraging everyone to take active participation willingly in he makes everybody to do something in to give 100% for the Kasoga. So please, sir, address the today's gathering.
Thank you, Prabha. Thank you, Shobha. At the outset, Endoscopy Committee, really I congratulate you, Prabha, for your excellent work you have been doing all this nearing a year. Probably from my side, this is the last but one program. That's what Dr. Dwarkanath was reminding me. Next month, I am finishing my tenure. And you all have joined hands and given wonderful programs in this 1 year, for which from Kasoga office side, I have to thank you. And Kasoga family thanks you for giving such a knowledge. Every session was filled with knowledge. The way you have taken the endoscopic webinars, you started with the basics, now some instruments, manage how to clean the instruments. From there, you have started. Really, Kasoga has benefited a lot from your from your team. Coming to today's topic, the galaxy of speakers, Dr. Ramesh is none other than he's an extended family of Kasago only. We don't know when he's going to get into the roles of Kasago office. We are all waiting. Ramesh, have you logged in? Not yet. Ramesh is one day other day. We expect Ramesh to be the president of Kasoga. That's what Ramesh is for Kasoga. With respect, another guest speaker, Dr. Rishikesh Pandit, Kasoga welcomes you, sir, and waiting to hear you.
Hello,
Prabha,
sir.
as usual.
All.
Yeah.
Thank you, sir, for giving me the opportunity to speak on the.
With respect to Prabha, the excellent topic you have chosen, because we have seen cervical incompetence, we have applied cervical chirurgical stitch, still it's giving way, and the only answer is probably the abdominal approach. And all these years, it was through the abdominal approach. Now it has become a laparoscopic approach. And we are all here to listen to you. I have seen, I have not done, because in our hospital, I have seen that we have invited the laparoscopic surgeon to perform a laparoscopic encerclage, and it had yielded a excellent result. Who had undergone, even after Shirotka's cerclage, it has given way and she had aborted. We got the result only after the laparoscopic abdominal encerclage.
Now,
With these few words, I invite Dr. Sheila Mane and my friend Dwarknath for this today's, and Soumya Mani for this today evening. Thank you, Prabha, for the opportunity you have been given. Thank you very much.
Thank you, sir, for the encouraging words. Actually, now Ramesh sir had joined. He has one more webinar next in same in endoscopy. This is endometriosis by ICOG. So he told that he's joining soon because he has to finish and shift there. Actually, I just want to give like a brief why I've chosen this topic, because this nowadays we are seeing so many of preterm patients incidence has increased, or we are picking up it in early stages.
Audio video.
Yeah. Hello.
Just 1 second, 2 minutes.
So, and we are facing a lot many laparoscopy surgeons are coming up with their own innovations in saving the preterm deliveries. So this was one of the hot topic today. And it has,
Ramesh sir?
yeah, he had joined thing. His voice is coming.
Yes, madam. Sir has been joined.
Okay. See, so many of the endoscopy surgeons are coming up, budding endoscopy surgeons and laparoscopy surgeons. They all are, this is a one procedure where we need lot of expertise and the skills. And every surgeon has got a different experience about this TLC during the pregnancies. So most of the surgeons who do it regularly, we cannot, catch them to demonstrate live surgeries and all during pregnancy. So this was the best thing where we can discuss freely on the webinar platform about the TLC during pregnancies. So that's why actually I'm very happy that Rishikesh Pandit doctor has immediately accepted in one call to share his experience and knowledge about his innovative techniques. Recently has got award for his technique also. Yeah. Yes.
Good evening, Ramesh sir.
Good evening, sir.
Good evening, madam.
So
Join
now we will
ಆಗಿದ್ದಾರಾ?
start with the first talk. So I
Okay.
invite Dr. Darkanath sir, who is our chairperson for the first talk. Dr. Darkanath sir is a very senior consultant professor and former head of the department of Siddhartha Medical College. Sorry, the AV idal ಸ್ವಲ್ಪ ಸರಿಸು. This, you take it up. Okay.
It's okay, madam. No problem. Brief
No,
introduction
sir.
is enough.
No. Actually, what happened, that is covering my. Yeah. So, sir is in Siddhartha Medical College from Tumkur, and his area of interest is high risk pregnancy, infertility, and gynec laparoscopy. Actually, I see sir always attends the Kasoga endoscopy webinars, and he has a lot of active interaction with us after each webinar. And
Thank you.
he
Thank you very
has,
much, madam.
yeah, he was a president of Tumkur Obsgani Society in 2013. And he has worked as an organizing secretary for Kasoga conference in 2024. So he has, he's an active EC member of KIGA also. Over to you, sir. You just
Thank you
carry
very
on
much,
for
madam.
further.
Yeah.
Um,
It is
talk.
my great privilege to introduce the legend of laparoscopy in India. That is
Yes.
our beloved Ramesh sir. So, as a human, really, sir is a very down to earth person, very much adorable, and touched the heart of many gynecologists. I think all of you agree with me. In fact, at his son's marriage, in fact, sir has come to our hospital to give the invitation. In fact, it was a big surprise for me, really. That was the type of association I had with sir. So, as you know very well, to have a brief introduction of our Ramesh sir, B. Ramesh sir, is clinical and academic impact, as you know, is very worldwide. Is recognized for significant contributions in clinical and academic circles, both national and international level. And as, of course, he's a well-known leader with the leadership qualities as chairman of Endoscopy Committee, FOXY, in 2018 to 21. He has got professional associations as the president BSOG in 2010, and his conference and workshop participation actively engaged as chairperson, organizing faculty and speaker, and of course, very well known all of us. The DRAGE conference is in fact hosted by him in every 2 years. And his surgical expertise, big surprise, he has performed more than 1 lakh major gynecological laparoscopic surgeries and hospital affiliations, visiting gynecological laparoscopic surgery at numerous hospitals across India and nationally, even internationally as well. He's got a lot of awards for his credit. He's has got legendary award by IAGE in 2024, Dronacharya Award, Karnataka Rajyotsava Award, Aryabhatta Award, National Award, like that, and he has authored more than 50 articles in national and international journals. Of course, as we know, his area of interest is more mainly on endometriosis, reproductive constructive surgeries, urogynecology, and gynec oncology as well. Over to you, Ramesh sir.
Hello, can you hear me?
Yeah. Yes, sir. Yes, sir. We are able to
Yes,
hear you,
yes.
sir.
Net problem ಇದೆ ಸರ್ ಸ್ವಲ್ಪ ನೆಟ್ ಪ್ರಾಬ್ಲಮ್
ವೈಫೈ ಕನೆಕ್ಟ್ ಮಾಡಿ ಬೈ
ಸೆಟ್ಟಿಂಗ್ ಹೋಗು
You can go
Hello,
for
Ramesh.
hotspot also.
Hello, Ramesh. Hello.
ಓಪನ್ ಮಾಡಿ
Hello, sir.
Hello. Ramesh.
Hello. I think he had joined. Actually, he had just called me that I have joined. Just some net problem is there. Yeah, I will call him.
ಇವಾಗ ಇದು ಓಪನ್ ಮಾಡೋದು ಆಡಿಯೋ ಕ್ಯಾನ್ ಯು ಹಿಯರ್ ಮೀ
Yes,
Yeah,
sir.
yes,
Yes,
sir.
sir.
We are able to hear you, sir.
yeah okay
Ramesh.
sorry for some net disturbance was there. I'm very sorry, Prabha. I know.
No,
Yeah,
no
now
problem.
Welcome,
yeah.
Ramesh. I was
Yeah.
introducing him
Hello,
to one
Durga
yes,
Das, Prabha,
yes.
and everybody.
Welcome, sir.
Today,
Welcome, sir.
yeah. So
Namaste, sir.
laparoscopic cervical encerclage. In fact, in India, the laparoscopic cervical encerclage was started by me and way back in almost 18 years and popularized by various people. So now, like when you compare second trimester cerclage, there is no evident role for second trimester transvaginal cerclage. So first we must understand there is no role for transvaginal cerclage, because without transvaginal cerclage also the outcomes are similar. That is McDonald. So now cervical insufficiency is not only cause of recurrent miscarriage, so it is the cause of premature labor also after 16 up to 28 weeks. So now painless dilatation of the cervix, you know that, and bulging and ruptured membrane. So the role of laparoscopic encerclage is before that. If already membranes are bulging and ruptured membranes, so it becomes a rescue cerclage. The results are not so good. If you can do it electively, I think that is the best way. And indications for transabdominal cerclage is like you must have had failure of vaginal cerclage. Patient must have tried maybe McDonald or modified Shirodkar, etc. And some patients have extremely short cervix, maybe because of congenital or maybe some surgery, etc. And secondary infertility with extremely lacerated and fibrous tissues, agenesis of the cervix, and of course, previous vaginal cerclage I mentioned. Contraindications, if already patient is in preterm labor or already aborting, you cannot do anything. If already chorioamnitis is set in, hardly you can do anything. And there is severe vaginal bleeding, you cannot do anything. Membranes ruptured, anything, you cannot do anything. And fetal compromise, there is no point in doing cerclage. So advantages of transabdominal cerclage, you can see here in the picture. So this is the level at which we place the McDonald, and this is the Shirodkar in between. And abdominal cerclage is the highest level of cerclage, which is at the internal os. So if you take anatomy and physiology, the incompetence is at the level of internal os. So if you are close to the internal os, the success rate will be much better. So I'm sure these vaginal people, they say modified Shirodkar is better, but Shirodkar doesn't go up to the internal os level because you are doing from vaginally. And laparoscopic encerclage, you almost go very close to the internal os. And especially in non-pregnant uterus, you can put the stitch at the level of the internal os. And so laparoscopy, advantage of laparoscopic doing during pregnancy or interval cerclage, visibility is better, and so faster recovery. All the advantages of minimally invasive surgery is there with laparoscopic encerclage. So advantage of interval cerclage, it is very obvious that during pregnancy, there is a, like manipulation of the uterus is a problem, and bleeding will be problem. So that is why interval cerclage is much better when compared to cerclage during the pregnancy. So that is why if the patient comes in non-pregnant state with cervical incompetence, so you must do the encerclage at the time, means interval encerclage has to be done. And earlier, how we started was we started long back, I think in BSCC, you cannot yeah, okay. So we used to use this port closure needle. So after bladder dissection, we used to pass the Marcelin tape with the port closure from anterior to posterior, and then again from posterior to anterior, and tie at the level of the internal os. Then next one, next. So this is the interval cerclage, how it is done. So and many times you don't have to dissect the bladder and create the window. You can do without doing it is safer to dissect because sometimes the tape go very close to the bladder. So that is why it is better to dissect the bladder. And if the vessels are not visible properly, you can make a window in the broad ligament. So you can so window is basically for visualization of the blood vessel so that the bleeding doesn't happen. So dissect the bladder down, And next is you create a window, and you take the tape from left to right and posteriorly and tie it. So it is a tying the tape is a challenge. You should step on the first knot, otherwise it may slip. So this is how you can see here in the interval circlage, we are almost going up to the level of the internal os. So this is how the interval circlage is done. So next is circlage during the pregnancy. So it is the same steps, code unavailable. I think this video is not open, right?
Okay.
So, okay, I think it is a similar step. I think Rishikesh Pandit will say how to do. This video is not opening. So it is similarly, like it is a similar step, except that there is no manipulation of the uterus. So you have to hold with your grasper the round ligament or UV fold or the peritoneal surrounding structures to manipulate and give the steep headlong. And creating that broad window ligament has an advantage that it is a manipulation is avoided, and it is a safe and visibility of the uterine vessels. That is very, very important. And also the possibility of puncturing the amniotic fluid is very less because you can see the needle where exactly it is going. So this is again the lateral window in the pregnancy, during pregnancy, how it is done. So this is also not opening. I was not ready. Yeah. So this is a pregnant uterus. So you can see, and sometimes the ureter will be very close. So you have to identify the ureter and lateralize the ureter. Otherwise, so in our series of almost 500 cases, we had one ureteric injury because of the previous adhesions. So the window is created, and accept and don't manipulate the uterus much during the pregnancy, because the bleeding can happen and there may be a laceration on the surface of the uterus, etc. So this is creating the lateral window, which is very, very important during the pregnancy, and the tape is taken from both the sides and tied. So you can see this safety, this making the window makes the procedure safer. And so this is the video showing the same thing. So this is the same thing. And you can see how the manipulation is going on by holding the peritoneum and the surrounding structures. Don't manipulate the uterus much. And you can do up to 24 weeks like this, like even if internal os is open without bulging of the membranes. So you can do, many times we have done up to 24 weeks and rescued the pregnancy. So the size is not a matter, because once you give the head low, so you can dissect the bladder and create the window and put the stitch around the cervix or the internal os. Main thing is we should exclude the uterine vessels, but sometimes there can be bleeding from the uterine vessels where you have to coagulate. Even if you coagulate uterine vessels on one side, nothing happens because there is sufficient collaterals from the other side uterine, and both uterine should not be damaged, because that will compromise the fetal circulation. So you can see here how the thing is done. And when you tie the knot, you give cephalic traction on the uterus by holding the peritoneal edge. So that is how it has to be, and it has to be tight enough. And after tying the knot, it should be checked on ultrasound whether the tape has gone inside the uterus or inside the cervix, and whether everything is okay. So we must do transvaginal ultrasound to make sure the tape is in proper place. And so this is our study, which was published in Harpage, what is that journal, from the Asian journal. So where we described the steps. This was long back. And so this is the article. And complications of, I think Rishikesh will cover during his talk. So injury to the parametrial vessels in significant hemorrhage. You don't have to worry much. You have to give compression with a atraumatic grasper. And so requires cesarean, suppose say 26 weeks or so fetal demise happens, you need to open the tape and so that the pregnancy can come out. So normally what we do is we do the posterior colpotomy and cut the tape through the posterior colpotomy. Whereas up to 10 weeks, suppose if there is an interval cerclage and if there is missed abortion, up to 10 weeks, you can induce abortion. After 10 weeks, it becomes difficult. You have to manually evacuate the pregnancy. That is the possible thing. And possible injury to the adjacent viscera, bladder, especially bladder and ureter, postoperative infection, and so these are all the other complications. And so this is one retrospective study which was published in Canadian Journal of almost 200 cases where, whether interval cerclage was better or cerclage during the pregnancy was better. And now this study of 200 cases, we proved that, the interval cerclage is always better because we had out of more than 140 cases, we had 4 complications in pregnancy group versus no complication in non-pregnant uterus. So I think, so this is the study objective which was done on 122 patients and 56. So this is the summary. And this is to compare the outcomes from almost 10-year studies. And we included 178 patients. And so like 122 versus 56. And so these were the exclusion criteria. And transabdominal post-conception was conducted on 56 patients. And this is the result of total number of pregnancies prior to interval cerclage. So we had more than 28 weeks of a lot of pregnancies. And so these are the results to see interval cerclage in 122 patients, but without any complication. Whereas in pregnancy cerclage, there were complications. And these were the indications of abdominal cerclage. And in two cases, we have to convert into laparotomy, not because of the bleeding, because of they were the cases of endometriosis, where there was complete obliteration of the pouch of Douglas so that we could not visualize. So then we had to open up and pass an artery forceps posterior to the uterus and complete the uh, encirclage. So this factor you must bear in mind whenever there is a obliteration of the pouch of Douglas or adhesions in the POD, it becomes little difficult. So then next is, so these are all the results. And because I don't have much time to discuss about the results. And of course, the laparoscopic approach has the advantage of reduced postoperative morbidity, short recovery period, short hospital stay, and obviates need for laparotomy. And of course, the advantage of laparoscopic abdominal is placed at the level of the internal os. None of these vaginal methods go up to the level of the internal os. Only disadvantage of abdominal cerclage is, I think LSCS, I think Rishikesh has a method, Pandit has a method to release the suture. Recently, we did few cases after seeing his video. So now there are methods to release the suture at the time after 37, 38 weeks, so that even after abdominal cerclage, the patient can deliver. So we must appreciate Rishikesh Pandit for this innovative technique, so that in future many people will do this removable suture, so that even after abdominal encerclage, the patient can deliver. So I think with that, I end my topic. And if there are any questions, please. I was a little unprepared, so I'm very sorry for that.
So,
Thank you very much.
excellent.
Thank you very much, Ramesh sir, for your
Yeah,
very crisp
Dwarkanath. Yeah, please tell
presentation.
me.
Namaste, namaste, sir. It was a very
Namaste.
nice presentation. So,
Yeah.
regarding the bleeding, it is what type of bleeding you encounter when you're doing the
It is
laparoscopy?
usually from the parametrial and uterine vessels, and mostly from the veins,
Okay.
in the broad ligament next to the uterine vessels. So whenever you are passing or dissecting, it can have this thing. So what you have to do is take a flat grasper and give a good compression and wait for 5 to 10 minutes. It will stop. Bleeding will stop. Otherwise, you can cauterize with bipolar.
Cautery is
Cautery is there, and it is mostly from the veins, and usually the uterine artery will not get cauterized because it is little deeper.
Okay, right, sir, right, sir.
Yeah.
Thank you, sir. Thank you.
Prabha, you have any questions?
Hello.
Yeah, Prabha.
Very nice one. Just I want to say, have you tried with any other material rather than Vaseline tape?
I'm not. Yeah, can you repeat the question, Prabha?
Sir, yes, sir. Yes, sir. Have you tried with any other suture material than the Marceline tape?
Yes, definitely. I have tried black silk, then Ethibond, Proline, anything can be tried, but nothing like Marceline tape. But Marceline tape is difficult for the method which Rishikesh Pandit has described, because the needle has to come through the vagina and again go back. So I think in only those cases, Ethibond or Proline is used. But if you are doing completely intra-abdominal, Marceline tape is the best.
Yes, sir. Yeah, any other questions? I think chairperson? Dwarkanath, sir?
No, madam. I think I asked one
Hello.
question. Regarding the bleeding, I asked one question,
Yes.
sir, actually answered.
Yeah.
And I think we don't have any questions from the audience.
Yeah. So thank you very much. So you can
Yes,
proceed with the
sir.
next speaker.
Yeah.
I'm sure there are very good
Thank you, sir.
speakers.
Actually, one question
Thank you very
I got
much,
in
sir.
the
Thank
chat.
you.
Yeah, I think there is
Yes,
one
sir. Thank
question.
you, sir. Thank you.
Indication
Thank
for
you very much. Thank you.
yeah. There is
For
a question
abdominal
here.
circulation. Yeah.
Indication for abdominal encerclage. So I told you clearly that indication for abdominal encerclage is previous proved cervical incompetence and any cervical shortening or abnormalities where the abortion or the preterm delivery is likely to happen. And mostly you must have tried with vaginal cerclage first once, at least once, either McDonald or Shirodkar. If that also fails, that is the thing. But in certain cases where suppose IVF pregnancy, very precious pregnancy, where you have to be very sure that she should not abort or have preterm delivery. So we have done many cases like that primarily without trying vaginal cerclage also. So that is the primary. In future, probably, the pregnancies are so important. So if you want to be very sure of to prevent the cervical incompetence, so you can apply cervical encerclage without trying vaginal cerclage also.
Yes,
And
sir.
apart,
That's a true with abdominal. That's a true with congenital uterine anomalies, right? No, sir.
yeah.
When you go for any laparoscopic surgeries, during that time also you can add this procedure.
Yeah. Suppose if you have metroplasty or unification of the bicornuate uterus, or say you are doing septate uterus, all these cases you can electively put cervical encerclage so
Yeah.
that you don't have to put the encerclage at the time of the pregnancy. And
Pregnancy.
there is a belief that, if you put a encerclage, the sperms will not go inside. Sperms are very
That's a wrong.
microscopic structure. They can go without with encerclage also.
Yes, sir. Thank you, sir. Thank you. It was a very nice start of this session. Thank you, sir. I think sir has to join the next webinar. Yeah.
Thank
Can
you.
we shift to?
Thank you, everybody.
Yeah. Thank you, sir. Mr. Arun. Hello, Mr. I would like to invite
Yes, ma'am.
the next talks, next chairperson's CV. I would like to invite Dr. Sheila Mane, madam. For madam had joined.
I think no, ma'am. I'm sorry.
She has not joined. If I will just call her AP. She.
Okay.
I think she is busy in one of the endometriosis webinar. Hello. Hello. Am I audible?
Oh, yes, ma'am. Yes, ma'am.
Yeah. See, she is busy in one of the endometriosis. Actually, these two webinars are going on side
Yes,
by
yes,
side. So it
yes.
is still 7 o'clock. So sorry, Dr. Madam could not join, but
I
she's
think
not picking up the phone.
Prabha,
Yeah,
Prabha, you
you
just
can.
proceed. Prabha, you only
Yes, sir, yes,
introduce
ma'am.
and you conduct. Just
Yeah, yeah,
proceed.
yeah, yeah.
Hmm?
Yeah, ma'am.
Okay, okay.
So I will take this privilege to introduce our next speaker, Dr. Rishikesh Pandit. He has got n number of awards, and he is very famous for his skill in not only in simple or advanced endoscopic surgeons, but he has done a fellowship in gynecological oncology, and he has got many awards for his surgical innovative skills. Okay, and he is a very good laparoscopy urogynecological surgeon, and he has I have seen and his videos are very much learning videos in YouTube. He makes the simple steps so simple and practically applicable, and I have seen his lot much of videos and got so many of innovative ideas for difficult cases, especially in case of fistula repairs and all. So over to Dr. Rishikesh Pandit, sir, and thank you for accepting the invitation for this very difficult topic of transabdominal cervical and laparoscopic transabdominal cervical during pregnancy, and he wants to present his innovative technique also. Over to you, sir, Dr. Rishikesh Pandit, sir.
Thank you, ma'am. Thanks for the kind words, and I'm really thankful to the Ramesh sir also for giving his vast knowledge about the laparoscopic cerclage with which he has shared with us. So I'm going to share you the my few cerclage videos recently which we have did. Recently, we have done the first time cerclage in a complete cervico-vaginal agenesis patient, which was the complete success story. So I will start with the positioning of the patient. So the steep head low is
So can
required.
you just share your, yeah, thank you.
Yes, ma'am.
Yeah, thank you, sir.
Is screen visible, ma'am? Hello?
Yes, sir. Yes, sir.
Yeah.
Sir, make it a slideshow, sir.
Yes, yes.
Yes, sir. It's done. It's
So
correct,
the
sir.
indications of the laparoscopic cerclage are the failed prior vaginal cerclage. It should not be done routinely without escaping the vaginal cerclage, gross cervical shortening with anatomical distortion, absent or amputated cervix like trachelectomy patient or a patient who are having the congenital cervical hypoplasia are the clear-cut indication. It is not a routinely alternative to the vaginal cerclage. That is the must thing you should understand. And it is indicated where vaginal placement is either technically impossible or has failed. So as I told you, the positioning is going to be the steep head low is required. Patient should be under general anesthesia. Uterine size is not matter. In cases of emergency cerclage, we can perform it till the 26th week when we want to achieve the viability of the fetus. So in cases of big size uterus, which are more than 24 weeks size, your trocar placement should be gentle, directing vertical so that you should not damage to the uterus. And if the uterus is of small size, like 14 to 16 weeks, should place the primary trocar at least 6 centimeter above the fundal height, and the lateral trocar should be placed accordingly at least 4 centimeter away on both the sides to the 10 trocar. As I'm an ipsilateral surgeon, I usually put the left sided two 5 trocars. There is most challenging part in the laparoscopic cerclage is there is no uterine manipulator we can use. Retraction is achieved using a traumatic graspers over the round ligament and the fundal surface without compromising the vascularity. At 14 weeks, posterior uterine space remain accessible. Beyond 16 weeks, bowel displacement and limited retrouterine access is slightly difficult. So how to perform the laparoscopic cerclage? Here I'm going to show you the video. It is done in cases of the didelphys uterus, as I stated. So first thing, we have to assess the uterine artery position in the didelphys uterus cerclage. Then we have to start with the dissection of the UV fold. Here you can observe the entire lower uterine segment has stretched and ballooned out.
Prabha, the slides are not seen. Dr. Pandit.
Dr.
Yes, ma'am.
Your slides are not seen. You are only visible.
Okay, ma'am.
You have not.
Just a minute, ma'am. I think they have to allow the.
Hello.
Hello.
You are supposed to chair the session. I thought you.
Is it visible now? No. Yeah, I think it's visible now. Okay. So is it visible now?
Yes, sir. Yes, sir.
Yeah, sorry. So this is the didelphys uterus cerclage, in which first thing we have to see the uterine location and the entire lower segment has bulged out. So we have to start with the traction on the round ligament with the opening of the UV fold. Observe my assistant is giving the upward tenting movement and my left hand is gripping the round ligament and giving the traction. Here you have to just apply the traction over the portion where you are going to dissect. As it's a didelphys uterus, we are expecting the left-sided uterine quite close to the uterine bud. Observe, as I have given the neck, the CO2 has gone inside the cervicovesical plane and opening the plane for us. Here you have to give the respect to each capillary so that you can maintain the bloodless field. Here I'm taking the help of a sponge stick, that is a gauze piece on a sponge holder. I'm inserting through the vagina so that I can mark out properly the cervix that goes into the anterior fornix and make that portion prominent. Here the creation of the window on both the side is going to be the second most important step, as your entry and exit of the needle can be visible, and this window you are supposed to take quite lower down till the level of the uterine arteries, so that whenever you are passing the needle at the level of the internal os, your entry and exit of the window can be clearly visualized. Observe, you should not rack any time on the vessel. So this is the window which we have created on the left side. Similar window we are going to create on a right side. For that, my assistant is going to put his grasper below the round ligament into the broad ligament window, come in complete avascular area. Here, the harmonic or ultrasound sometimes work better, as you can just use the active prong to cut. But here I'm using the shearer for the same. Once the window has created, we have to again take it down till the level of the uterine. Here you have to be really cautious that you are not going to damage any kind of vessels at this point. So you have to push the bladder entirely lower down. If you are in a wrong plane, dissect with the sharp dissection. Here you are supposed to avoid the entering into the bladder. For that, you should have the proper capillary markings in your, or should be visualized, and you should be print in your mind those capillary marking, that you should see the complete vertical capillaries. That is going to be the, again, you can see the video, or you're seeing my video. Hello.
We cannot see the video. We are seeing you only. I think there is something.
Till now we were seeing. Now,
Seeing, but I'm
past
not.
few seconds.
I
Yeah,
think the,
now again you were. I think screen sharing is getting stopped between.
yeah.
Mr. Arun,
Yes, sir.
can you make him like this thing? Why his screen sharing is getting stopped?
Uh, s- uh, Somewhere video is cutting off, man. So can you send that file, sir, so that I will share it?
I want to forward that video actually.
Okay,
That's
okay,
why.
okay.
This time again sharing it. Then I
You
will,
can share
Yeah,
again, sir.
you can share again, no problem.
just a minute.
Whether it's a separate PPT or it's a video itself.
The video
It's
itself.
PPT only, actually. Yeah.
Continue to share. Just a minute, ma'am. I'll share it once more. Yeah.
Yeah, now we can see.
Just a minute. Just a minute. So we are here. So you can see the entire dissected uterine arteries on both the sides, and we have dissected the central portion. Now the next step, we have additionally dissected this peritoneum so that it should not get entrapped. The most crucial step is the piercing of the needle. Observe, there is always you are going to get a space between the uterine artery and the cervix. It's a completely free space, and you have to enter through that space only. That means you're not supposed to enter through the cervical content, or you're not supposed to go too much close to the vessels also. If you go through the cervical content, there are chances that you might trigger the contraction. Here you are supposed to take care of the ureter here, which you can see here on a lateral side. I previously I'm used to put the needle from anterior to posterior. Now I shifted to piercing the needle from posterior to anterior, as we should always try to come from difficult area to the safer area. So when we are piercing from posterior to the anterior, we are not going close to the major vessels or neither the ureter. So that is the another important steps which you can do. So I will transfer the tape from left side to the right side. Here, if there are any kind of bleeding, you can definitely go and coagulate the vessels. Most of the time, the bleeding is going to occur from the uterine vein, not from the uterine artery. When you keep the needle before giving the final thrust, you have to see the tip. from which area it is coming, and then you have to give the proper thrust. A nice tip Dr. Ramesh sir has given that you can use the port closure needle to pierce from anterior to posterior to bring the tape onto the anterior side. Finally, after taking out the tape, you have to put at least 5 to 6 knot. Here you can see the tape's location exactly at the level of the internal os. The most important thing is that you're not supposed to tie the knots completely on a one hand. That is, here I'm putting the knot on my left hand, but if you go on tying on all the knots on your left hand, it is going to form the sliding knot. That means when uterus get contraction, the cervix can be easily opened up. To lock this knot, you have to put the knot on your right hand also, so that it can form a complete square knot and sustains there. So that is the important step you have to understand. So that is the final picture. So pitfalls of traditional cerclage are you need the LACS or the hysterotomy if there is a leaking, if there is a chorioamnionitis, or there are cases reported where the tape migrated into the bladder, and in cases of PROM happens immediately after the cerclage, you have to do the posterior colpotomy under the anesthesia for the removal of the tape. So for that, we have completely modified it, which help us for the removable technique of the cerclage. So initial steps are going to be the same. We are going to give the traction on the round ligament. We are going to open the UV fold, dissect and push the bladder down. After pushing the bladder down, here you can see the complete vertical capillaries, which indicates that you are in a proper plane. Not a single capillary is bleeding here because we are in a proper plane. After opening the UV fold, now we are opening the broad ligaments, posterior leaf, and now henceforward the steps are going to change. So from this window, we are going to enter into the denonvillous fascia. We are going to open into the denonvillous fascia, push the rectum downwards. And as we are knowing, this is a complete avascular plane. Again, my slides have stopped. Just a minute.
Just my turn on the other talk like this.
Yeah. Zoom.
ಇದಕ್ಕೆ ನೋಡ್ ಬಾಯ್. ನಾ ಈಗ ಅನ್ಕೊಂಡ್ರು
Sir, kindly unmute, sir.
Hello, Dr. Rishikesh, kindly unmute yourself. Hello, Dr. Rishikesh. Hello.
Yeah. Yes, ma'am. Yes. Just a minute.
Yeah.
Yeah. So after opening the denonvillous fascia, we are pushing the entire rectum downwards, so that when we are going to pass the ethibond from the vaginal end, it should not go into the rectum, it should come from the vagina into the abdomen. So as it is a complete avascular plane, we have to just do the
internet problem ಅವ್ರದ್ದು.
Use the divergent force for the creation of a space side in a similar way. And here observe, I'm going to use the ethibond suture. One may use the proline. Again, the entry side should be specific. It should be just medial to the vessel, not going through the cervical content. Then we are going to pass the port closure needle from the vagina into the abdomen, so that we can grip. First, I'm feeling the where I'm going to come through the fingers, and over that I'm passing the port closure needle, which I'm going to grasp and pull into the vagina. And similarly, then from the other side, I'm going to reinsert that port closure needle along with the thread. So it is going to create a loop in the vagina, which I'm going to show you in next steps. And once the thread along with the needle comes from posteriorly from the vagina into the abdomen, the last step is going to be the same, that is piercing it from the posterior to the anterior. Now you can watch this kind of loop is formed in the vagina, where I'm going to put a knot, and that knot is going to be get fixed into the posterior fornix. Is there any lag? Is there any lag? What you're seeing, ma'am? Can you see the vaginal end portion of the thread?
No. There is little lag between what you are telling and what here display is going on. Might be some internet
Okay.
problem.
Yes. Fine. Okay, I will tell
Now
you.
we can see just the POD.
Yes, ma'am. So that's what I'm feeling, that what I'm telling and what you're seeing, there is a bit of lag.
Yeah. See,
Fine.
till what gestational age you can use this, till that lag get
Ma'am,
covered?
till the 14 weeks, we can definitely do this type of circlage. But I can
Okay.
tell you,
Because after that POD get obliterated.
yes, it's really challenging after 14 to 16 weeks
Yeah,
to put that go into the POD, but
POD.
still till the
Yeah.
14 to 16 weeks, you can definitely go there and dissect the denon fascia. Now you can see there that I'm putting a needle again, but what I'm seeing and you're seeing is different.
Now
Okay.
Veris needle has come.
Yeah. The Veris needle has come, and
Yeah,
we
it is
can
holding the
the ethibond and
ethibond,
going
I
out.
think. Yeah, ethibond is going out.
There is bit network issue, I guess, because I've finished the video, and you can see there the entry of the needle and exit of the needle there.
Ethibond is of which number it is?
It is 0 number ethibond, ma'am. It's quite thick. I used intentionally the ethibond as because it is a cardiac suture. It's having a good strength, but one may use the proline also for putting the same thing.
It's number one.
It's 0 number, ma'am.
Zero.
You can use any kind, but for the you have to choose the specific needle so that you can easily manipulate it. Yes, you can see. Fine, ma'am. Give me just 1 minute. I will just.
Yeah. No problem.
I will join again through the Zoom proper. I have joined through the Safari. That is the issue. Just give me a minute, ma'am.
Yeah. No
Start
issue. We all want to see your video.
Prabha, what is happening?
Actually, no, he is getting lot of problem in joining. So
Hmm.
can we tell him if he asked for 2 minutes to join through proper Zoom
Do
link?
we
He has
have
joined
one more? Why
Safari.
don't you present your thing and then
Yeah,
we
yeah, yeah.
can,
I can. I will just.
because this we cannot waste the people's time. No, see, so many
Yeah,
people
yeah,
are
yeah, ma'am.
waiting. No,
Yes,
we
ma'am. Yes,
cannot do
ma'am.
that to the
Actually, it's
viewers.
the. Yeah, yeah, ma'am. I will
You
just.
please
He asked
present.
me for 2 minutes.
No, that's
Yes,
okay.
that's
We'll
why
see when he
I.
comes and we'll see. Okay.
Yes, ma'am.
You
Yes, ma'am.
start and then we'll take him in. No problem.
In between, yeah, after at the end we will
No,
take.
you finish. No, you finish. Be a little
Okay,
quick
okay.
because people, their
Yes, ma'am. Yes,
practice
ma'am.
will
Sure,
start.
ma'am. Sure,
How
ma'am.
much
You are
time?
right, ma'am. Yes, ma'am. Yes, ma'am. Yes, ma'am. I will. I will just take. Um, I will just. And I will inform that thing because he has uh,
No, you
been.
can ask Arun to
Hello,
call him and inform him. Arun must be having his number.
hello, ma'am.
Yeah,
Yes, ma'am.
yeah,
Actually,
yeah,
I joined. There is a bit of issue
yeah,
with.
yeah. No problem. Yeah, you can.
Extremely sorry, ma'am. I can
No
share. I
problem.
can start with my second video. So can you share? Hello.
Yeah, it has shared. Yeah, yeah, it has been shared.
So this is the circle arch I have performed in the completely cervical agenesis patient where the there is not possibility to
Yeah,
perform the vaginal circle
we
arch.
can see.
So yeah, ma'am. So for the embryo transfer also they have to take the 4 to 5 attempts, and then we have performed this kind of circle arch. So here when there is absent of the cervical portion, then we have to take the help of the uterine vessels, so that if
Apurva.
you do not find exact location where to perform the or put the stitch, we have to skeletonize the bilateral uterine arteries completely and then put the stitch. So here you can observe my assistant is just opening the prongs and giving a caudal pressure to create the bubbles. The important thing is that you have to dissect always into the bubbles and do not try to damage any kind of capillary so that it can bleed and obscure your field. The rest of the steps are going to be the same. We are going to create a window. Here you can observe the uterine arteries are quite big. I'm going to create a window. Most important thing is that you have to take this window caudally till the vaginal portion. Now we are starting the exposing the uterine vessels here. As we do not know whether it's just a unicornuate horn or a complete didelphys uterus. Again, it has stopped.
Yeah.
I don't know why it's
See,
happening.
Dr. Rishikesh, can
Yeah.
we do one thing?
Yes,
With the
ma'am.
last talk, I will just finish off. Till then, you correct your technical thing because everybody wants to see your modified technique. And that's a really very helpful for others.
Yes, ma'am. Fine. It's visible, ma'am. It just take 5 minutes more
Yeah,
because it.
yeah, I know. Actually, I have gone through your this technique in even AAGL conferences. You got the award for that time.
Yeah.
That I have
Now he is
shown.
showing, na Prabha. He'll
Yeah,
finish
yeah,
it.
it is seen, madam. It is seen now.
Yeah,
Mm.
yes, ma'am. So
Just
I
he
want to
has to
show.
tell the principal. That's all.
Yeah, that I have shown, ma'am. This is
Yeah.
here. You have to do the only thing that you have to go medial to the vessel, create
Yeah.
a window, and pass the tape, so
Yeah.
that there is no need.
This
And
is
here
similar
there's
to
a.
what Dr. Ramesh does, no? Similar to
No,
what
no,
he does.
sir,
Yeah.
madam. Here the needle will go into the vagina.
Okay.
From there, we have to tie the knot and then we
Okay,
can cut
fine.
the
The
knot from
second,
vagina
ma'am,
itself.
Okay, we can
that
remove
video.
it from there. Correct.
Mm. Just a minute, ma'am. This is the video. I think you have seen till this portion. Okay, just a minute. So we are here into that portion. I will show this video and stop, ma'am.
Yeah, yeah.
So this is the where the loop has formed. This is going to come in the vagina. Okay. We are going to put a knot there, and that is going to into the posterior fornix.
How do you enter from the peritoneal cavity into the vagina? How do you enter?
Madam, that has been taken through the port needle.
Port closure, ma'am. So this
Okay.
is the ranunculus fascia which I
Port
have
closure needle.
dissected.
Okay.
Needle that I have placed from the vagina into the. So this I have piercing from anterior to posterior, taking it out to put the port closure needle which comes inside the abdomen, and through that gripping the thread I'm going out, and again from the other side I'm going to put that needle inside the abdomen. So I'm going to form a loop in the vagina, ma'am. So that as needle has come, and now this needle is going to get pierced from posterior to anterior. So there is one loop in the vagina. This is the loop where I'm going to put a knot, and this knot is going to be in a posterior fornix. And lastly, I'm going to pierce the needle from posterior to the anterior and tie the knot anteriorly. So when you want to cut the knot, you have to just go into the vagina, pull the knot and cut. So this is the location of the ethibond which comes there. That's it. So this is another video which I have shown, and this is the first time which we did the laparoscopic cerclage in completely cervicogenesis patient, where we have first anastomosis done between the cervix and the vagina. After that, she gets conceived naturally, and after that, for the cervical funneling, we perform the laparoscopic cerclage. This is a bit challenging as because this entire plane has exposed previously, but the steps are going to be the similar. Here you can see there are dense adhesions, because of which bladder dissection is going to be difficult. But if you use hormonic, not a single capillary is going to bleed. We have formed the both-sided window. Again, you have to take the help of the uterine arteries here as an anatomical landmark, and you are supposed to go medial to it for the piercing the needle from anterior to posterior or posterior to the anterior. So this becomes a bit difficult when you're piercing the needle from anterior to posterior. So now I have shifted completely from piercing the needle from posterior to the anteriorly. So this is the first time you can see there is component of the endometriosis also into the POD, but we are not going to damage any kind of structures there or night. The tape is going to, it's not going to be difficult to pull the tape from that side. Now I'm going to pierce the tape from posterior to the anterior, and it should become medial to the vessels, not going through the cervical content. Even though there is some amount of bleeding, that is going to stop once you tie the tape. So this is going to be the final picture. This is the first time in the world we have performed the laparoscopic cerclage in a cervicogenesis patient. First we have anastomosis, then the anastomosis, and then we have put the cerclage in it. So the troubleshooting while during the pregnancy are the chances of hemorrhage. You can directly go and coagulate. If leaking occurs, you can go by opening the POD and cut, or you can, if you have done the modified cerclage like what we have shown, then you can directly cut the tape and remove it, and patient can be delivered vaginally. And the last thing is the hourglass formation, that is the some amount of the amniotic fluid gets entrapped in the cervical canal. So that can be taken care by the, either you can you can do the amnios reduction and put a cerclage, or you can use a Foley's catheter, inflate it so that the membranes can be pushed back, and then you can do the cerclage. So that's all. Thank you, ma'am. Thank you for all the opportunity given by you and Kasoga.
Yeah. Thank you, Dr. Rishikesh. In spite of little technical hassle, you could make it But actually, just I want
Yes, ma'am. Hello. 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 Am I audible? Hello. Hello. Sorry. Hello. Am I audible?
Whether you are
Hello.
uh,
Am I audible? Yes, ma'am.
see, you just unmute yourself.
Yes, ma'am. Sorry, ma'am.
Mute.
Not. Yeah, I've done the unmute. Am I audible?
Unmute yourself. See, I just firstly, yeah, you are audible.
Yes. Yes, ma'am. Hello. Hello, ma'am. Are you audible? I'm audible.
Yeah, actually, am I audible now?
Yes, ma'am. You're audible.
Hello. Yeah.
Yes, madam.
See, yeah, my question, Arun, what's the problem going on?
No, ma'am.
You
From my side, nothing, ma'am.
can hear me, Arun? The same.
Yes, ma'am.
Hello, somebody has. Okay, I think
Yes,
Rishikesh
ma'am.
has got
Bolo.
little problem. See, what I want to ask is,
Yes,
you are
ma'am.
instead of
Hello. Can you text, ma'am?
tape, you are using a hello.
Hello.
Yeah,
Hello.
other yeah. So I think we will take that question. I will invite the next chairperson, Dr. Soumya Mani.
Hello, ma'am.
Hello, whether she had joined?
Yes, ma'am.
Yeah, thank you, ma'am. Thank you for joining. Yeah, I actually, you introduced the Dr. Soumya Mani. Hello. Arun, please put hello, Mr. Arun.
You can see that, ma'am.
Yes, yes.
Hello. Yeah, ma'am.
Good evening. I'm Dr. Apurva Gupta. I'll be introducing Dr. Soumya Mani ma'am. Ma'am is Ma'am is a senior consultant with over 25 years of experience. Her fields of interest is high risk pregnancy, infertility, endoscopy, and preventive oncology. She has been awarded multiple awards, and she has been the past secretary and president of Hassan OBG Society, chairman of Adolescent Health Committee Kasoga 2325, chairman for Women's Doctors Wing IMA, vice president for Karnataka Scientific Research Center. Ma'am has been involved in many social care activities, conducting CA cervix and breast cancer camps and multiple health awareness camps. She has also conducted more than 200 camps in rural areas. We welcome you for the webinar, ma'am.
Hello.
Yeah. Hello.
Yeah, madam.
Yeah. Thank you, Apurva. Thank you for your kind words.
Yeah.
Shall I go ahead?
Yes, ma'am.
Yeah. Now, it's my immense pleasure to introduce Dr. Prabha Desai, today's speaker, the most energetic endoscopic surgeon. We are all proud to say, ma'am, you have been associated with Kasoga and taking us to a very higher level through so many webinars. Just by sitting within the four walls, you have been connected us with so many leaders of the uh, India. Hello.
Yes,
Yeah,
ma'am, we can.
ma'am is a Dr. Prabha Desai. She's a consultant endoscopic surgeon from Desai Memorial Hospital, multi-specialty hospital, Gadag. And first one to conduct in the North Karnataka, the IAGA training course in the gynec endoscopy, and also the Rajiv Gandhi University Fellowship in the minimal invasive surgery. She has been affiliated to lifetime member of IMA, Foxy, IAG, ISAR, and GOTS, and two-time elected president of GOTS and Kasoga Endoscopy Committee chairperson for the year 25 and 27. And she has been awarded with many few to say Golden Jubilee Award member um, for
It's
the
okay, ma'am.
best thesis.
Sorry.
Yeah, and best academic award of the Gadag, and so many awards like this. Over to you, ma'am.
Yes, ma'am. Thank you, ma'am. Thank you for
Thank
kind
you.
words. Actually, little bit technical issues and lot much of webinars are going on Wednesday only. So much of
Yeah.
disturbance, but I am really happy to share my talk on this. And actually here I now two talks has been covered about the what are the indications, what are the how we should deal with the in during pregnancy, how should put the laparoscopic cerclage and all. I am taking in different way of complication, challenges and troubleshooting in TLC. And this I have projected my journey of learning, which most of the aspiring gynecologist or budding gynecologist will can take a few points and they can build their own skill on this talk basis. So my objectives were are uh, yeah. So my objectives are understand the challenges in interval and pregnancy and during pregnancy TLC, identify intraoperative and postoperative complications, learn the practical troubleshooting strategies, and improve the surgical safety and outcomes. See, what we have seen till now is actually a tip of iceberg kind of phenomenon, where we are seeing technically how we should put it during pregnancy, during interval cerclage and all. So I will show you the other side of this procedure. So right now, somebody were asking me about the what are the indications. So usually we put abdominal cerclage in failed vaginal cerclages during the previous pregnancies or during the same pregnancy. In another case, I'm demonstrating that you've done the best in and some uteruses are very fragile, very soft, they will not budge to your vaginal cerclage. That time you can shift in nice second time to abdominal cerclage, or very short or absent cervix as a vaginal agenesis, or by surgically the cervix has been amputated, such cases. Then as I said, prostrachelectomy or congenital cervical defects and extensive cervical surgeries has the patient has underwent the extensive cervical surgeries. Okay. Or as I said, in very broad cervical, this uterine septum and failed previous cervical encephalopathy in such cases with recurrent mid-trimestral losses, you can go plan for interval cerclage. When the TALC, what are the challenges with TLCs? There are the TLCs related challenges are challenges related with the anatomy, with previous surgeries, pregnancy status, surgical technique, and complications or after procedures. So we have to overcome all these challenges. We will see how we can overcome all this. Okay. So next is now we will go one by one. What will be the intraoperative problems? Okay, so first problem occurs during in the interval encerclage. It's okay, you can identify all the anatomical things, but during the pregnancy, when it is a distended, especially beyond 14 to 16 weeks, usually it is a problem with identifying the cervico-ischemic junction there because of the distension and because of the if you are putting at the onset of the preterm label like bulging membrane or the already fetus has come down in the lower segment, that time it is very difficult to identify the cervico-ischemic junction. And in cases of any previously operated fibrosis cases or previous cerclages has been failed that time and previous any surgeries. So what is troubleshooting in interval cerclages? You can put a uterine manipulator or Hegas dilator and then push the uterus up, and then you can identify the this cervico-ischemic junction. Okay, then you should dissect the bladder very adequately so that you will not put the tape on the bladder. Then identify the uterine arteries as a landmark, as just now Rishikesh was telling, that use as a uterine artery as a landmark to know the your cervico-ischemic junction. And in case of he was demonstrating the vaginal this cervical urgenesis patients. That time uterine artery acts as a landmark, and use transvaginal fingers if needed. Okay. Then posterior window creation difficulty. Okay. In cases of adhesions, obesity, or limited in limited space in the abdomen, that time you will get this problem. Then what we should do is create a window close to the uterus. Don't go little far. Okay, I will show the when I have gone in a few initial few cases little far what has happened. That will be my next cases I will show. Then use a blunt dissection previously. Don't use a sharp dissections or energy sources directly. Then avoid. You should avoid the rectal injuries by going if you go nearer to the uterines, you will avoid the rectal injuries. So this is one case scenario where patient's profile, that is secondary infertility to mid-trimester losses at 18 to 20 weeks. We have put in last pregnancy, McDonald's cerclage has been failed during last pregnancy. It has been diagnosed. They have come for interval assessment of the cause for the her MTL. Then we found that there was complete uterine segment with a broad fundus, very short and patulous cervix. So we planned for the complete septal resection and the T12. So what was what was the challenges during this? This patient was UV fold. There was no space. Okay, because the uterus was so bulky and cervix was very bulky and hard, we could hardly get the UV, space for dissection of the bladder. Then there was lateral space was very narrow as the uterus was also bulky, and we have and unable. I was unable to go around the cervix. Okay. Then my technical error was I was doing in initial days of my practice. That time my techniques and I may not be properly got the idea of opening the UV fold and all, but usually we don't open the UV fold for all cases of interval cerclage. But these cases of bulky uteruses and bulky cervix, we need the broad ligament to be opened. That I learned from this case. Then avoid what we should do here. I use this muslin tape, but I straighten the needle. You know, this straightening of the needle has changed its curve, and even though I tried from anterior to posterior, posterior to anterior, I could not go around the vessels, means through and through. They were going into different planes, or it was piercing the cervix. Okay. And in laparoscopy, usually as I told previously, I was reluctant to open the POD, thinking that it was interval cerclage, but you can see here there is a very narrow lateral space. Okay, so I opened created a broad ligament window, and then again I have tried. Still, I was not realized that I could not have made the needle straight. Okay, this straightening of the needle will lose the curvature. And see here, the chances I have not gone medial to the, sorry, I have not gone medial to the uterines. So again, I took out the needle, and ultimately I opened this case and then completed the procedure. Okay, so these all are the, it looks simple when you are seeing the others operating, but when you start operating in different kind of patients, these kind of challenges may come. So next is where we start. Slide is not moving. No. Wait, my slide is not moving. It has got stuck. Just give me the, yeah. Just, okay. No, don't go there. Here. The slide has got stuck actually. Wait. I think today's day is not good. It is, don't restart. Wait the program to respond. Wait the program to respond. So when the PPT is loaded with the videos, this kind of problems will come. So till then, I will just go ahead with the next one of my very, problematic case where actually she has come with uh, actually two interesting cases I wanted to present in this and how we have overcome. Okay. So here, one case was, I will show once this PPT will start responding, I will show, don't touch it. I will show how those cases were managed, this picture and all. But before that, I will just discuss the case scenarios. One case was 20 para, para 8 and living 0. Okay. And this was, gravida 8, para 7, living 0. She came at around 15 weeks of gestation with, of course, that all were mid-trimester losses. So I have put cervical, her Shirodkar sensor class. That time cervix was actually very patulous, but soft. But I could successfully put her Shirodkar's vaginal cerclage by pushing the bladder up. Okay. And after 2 months, when she was around 23 to 24 weeks of gestation, like this was put on first cerclage at 16 weeks, and after 2 months, she came with again the membrane bulging through the, and the cervical Shirodkar's tape was failed. Shirodkar cerclage has failed. So, being she was para 7, I thought of putting her abdominal encerclage, and we could do her cervical encerclage successfully. Okay. And that was her os membrane we pushed inside and with little difficulty also, but the procedure went well. We put her a proper high cerclage. Okay. And after 1 week, she came with actually complaining of the abdominal tenderness and telling that she has been discharged actually after 1 week. And after that, she came with abdominal tenderness, and the overnight she was having a contractions. So when I touched her abdomen, it was a severe tenderness. So, and I done the scan. Actually, it was a rupture uterus, intra abdominally it has ruptured at the level of the where we have put the stitch. Above that the uterus has given the way, and it was as if you have taken a planned incision for hysterectomy. Okay, so then just the membrane was bulging, baby was IUD, the full sac was inside the anterior compartment. So I just took out that opening the abdomen, opening just after the opening abdomen I could see that, and then I took out the delivered the baby and take out the stitch and sutured, and I convinced them that her uterus is so fragile. She was not having previous any history. Still it has ruptured because it was a very soft uterus. So I just done her tubectomy. So these all are the practical problems. We should understand there is some limitations for every procedure. Even if you do technically correct, the body may not accept it. It will throw the baby in one or the other way, either down or from your supra stitch level. So this was a one case. And second case is also very interesting. She is still her pregnancy is going on. She's now 28 weeks, but when she has come to us at 22 to 23 weeks of gestation with full membrane bulging, 2 centimeter dilated uterus, but no abdominal contractions. So we thought of putting her abdominal encerclage. I have posted it. It was actually in the night hours and it was an emergency. So I put her Foley's from the down, push the membrane inside and took her for transabdominal laparoscopic cerclage at 23 weeks of gestation. As the membrane were bulging, Foley's was inflated and the baby was pushing down. So I could not, it was a very difficult to create a lateral window on the right side. On the top of that, because of the narrow space, on the top of that, the patient was induced with this vecuronium. Actually, the anesthetist thought that is a best drug at this gestational age. So he has induced, but I was not getting the proper relaxation. So he has repeated the dose. But after repeating the dose, also I was not getting the proper relaxation, and she was not getting her this thing. So, and while trying for her in the on the right side, when I was trying to dissect for the lateral broad ligament window, the bleeding started. Actually, I could not make out from where that bleeding was. So I decided, and it was taking a long time, and she was developing a hypercarbia signs also. The ETCO2 was going above 50 and all. So I just abandoned that procedure, and then I converted it to abdominal incision. I took at the financial incision, and I completed the procedure by opening the abdomen. Okay, and we have added the vaginal stitches also. From the vaginally, I added the cervical, these womb stitch I have done, so that I wanted to obliterate it vaginally also, and then took out the inflated Foley's. But after that, patient was not coming out of the anesthesia. It took long time. So we found the cause that she has developed the pulmonary edema. Okay, and we have to, at midnight at 2 o'clock, we have found that she has went into hypercarbia. Okay, and yeah, close the program and restart. We went into the hypercarbia, and she so soda backup has given, calcium gluconate has been given, and we extended her on the ventilator. Lasix has been started. Okay, and then she, of course, after 6 to 7 hours of ventilation, she came out of the ventilator once we treated for the her the pulmonary edema. Okay, after but the problem is that when we are handling such a pregnant lady with laparoscopically, we have to take care of all kind of all aspects of the problem. Go next. All aspects of the cares has to be taken, not only the surgical techniques, because patient has to go for multimodal management, and the pregnancy itself is a high risk condition. Okay. And after that, we have what problems we have faced. Just let it be. Wait, Apurva. So I think now everybody is able to see the screen. Soumyamani madam. Hello. 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 Anybody is here? Hello. Am I audible? Hello.
Yes, madam.
Yes, ma'am. You are audible. Please go on.
Yeah. See, so this thing we have to think of. I will just show those things when the slide will come that time. So after that, my problem was whether because of the pulmonary edema management, I could not make her, give her head low as it was demanding for her pregnancy to continue. I have to keep her propped up. I could not even do her spirometry, give her recovery. She needed almost 5 days of Lasix and and oxygen supplementation. And after that, she recovered, and she is now 28 weeks. And again, after the day before yesterday, she came with a membrane bulging. Okay, even though we have put the abdominal cerclage. Okay, and again we have put her head low and given her prophylactically everything, steroids and all those things. Okay, so these all are the practical problems which we have to think of before putting the abdominal cerclage during pregnancies. So we have to think about maternal aspects also. So this what other risks like bladder injury risks, like adhesions, the problems will be when there were previous cesarean sections. That times the adhesions and difficulty in taking out the or hysterectomy, dissecting the bladder. Then how we can prevent? Take a infraumbilical midline port for easy bladder dissection. Okay. Then you should have a sharp bladder dissections. Stay close to the uterus, and adequate bladder reflection has to be done. Okay. If injury, otherwise the tape may get eroded into the bladder. And if even if injury occurs, don't worry, you can suture the bladder anytime with a 2 layer of sutures and keep the Foley's for 7 to 8 days. So there are multiple pregnancy related challenges, like challenges related with increased vascularity at the lower segment, enlarged uterus, risk of miscarriage will be always there. So what are the tips? Minimum uterine handling, low insufflation pressure, like I usually maintain at 10 to 12. Okay. But really, I am telling it is difficult to operate with low insufflation pressure. And to decrease the venous congestion, this idea has been given when I discussed with one of the senior, Dr. Vikram Koth. He does a very nice surgery, but he was unable to do today's webinar. So he was given me an idea when I was discussing with him that he takes out the head low before pricking the needle. Okay, so that there will be no much venous congestions will reduce around the uterus. And then not to remove the inflated Foley's immediately after tying the knot tying the knot. He keeps the Foley's for 2 days, and he monitors the CRP of that patient so that the membranes will not again come out of till the suture get fixed or little fibrosis starts. Otherwise, immediately the membrane comes out of the even if you tied the knot. Okay, this has the same thing has happened with my case, that what I told, that 28 weeks she's continuing. Then management is you confirm the fetal cardiac activity post procedure. Then progesterone support has to be needed for such pregnancy related patients. Close follow-up is required, and counseling is crucial preoperatively. So these all are the two images of cardiac activity of the patients. Actually, this is one video. This is intraoperative video. You can make out how slow is the cardiac activity. Patient has gone into bradycardia post-procedure, immediate post-procedure. Okay. And yeah, and this is after 12 hours of the procedure, patient was see, now the patient has, a baby has got its cardiac activity at a normal level. So these all things we have to monitor. See, this is a case scenario, what I was telling of the rupture uterus. Almost this, actually we have, this is a cervical stitch when she has come for the second time at 24 to 24 weeks, around 23 to 24 weeks. She was having this cervical stitch in situ, but the membranes were bulging. This was her abdominal this thing, fundal height, and these were the port placements. Okay. And what error has happened means these patients also, if you go little far from the uterines, so this problem will occur. So I was going into the, I don't know after playing this video whether this will hang. So so here I could put the, actually you can see this area here where I went actually very much lateral, and I was almost going to the pararectal space, and I was getting the internal iliac artery and vein at that spaces. Okay. Then I realized, no, I have to go little medial, and I had gone little medially, and then completed the procedure at the broad ligament. So I took the needle from anterior to posterior, medial to the this thing, and on the right side you go from back to anterior. Okay, from behind to posterior to the anteriorly. Actually, it's little difficult to, if your needle goes through this little part of the cervix also, it is very difficult to pull out. So for avoiding this problem of vascular erosion, better to soak the marceline tape into the xylocaine jelly for 15 minutes prior to the procedures. Means once you start the procedure, port placement and all, that time only you can put it. This also I got learned when I discussed with my senior. So this is anterior knot I have placed. Okay. So while placing the knot also, you have to see that you are placing just above the membrane which you have pushed. Okay. And in spite of that successful surgery, this is my day after post-surgical day 10, patient came with a rupture uterus. And this is a, just I opened the abdomen, and this was the scenario. This was a dead fetus. Almost the placenta was also separated itself. And here you can see the uterus has ruptured by itself spontaneously, and the stitch was in situ. Here is a stitch. We can see that stitch is in situ. Okay, I took out that stitch. I cut open. Okay, just above that stitch only uterus has ruptured, and then I sutured the uterus and then the tubectomy for her. So uterine artery bleeding, as we have said, while passing the needle too laterally also it may happen, or when you are creating a lateral window too laterally when you don't have a much space, that time also it may happen. Or means vascular bleeding, not only uterine artery, but you may damage the other vessels also. So, and when there is especially when there is a poor visualization, the troubleshooting is immediate bipolar coagulation, pressure with the gauze, clip if the bleeding persists, and avoid blind suturing, please. You can open the abdomen, convert into open, but don't do a blind suturing. So how to prevent? Pass the needle medial to the uterine vessels, create a proper broad ligament window, and soak the tape in xylocaine jelly to avoid this thing. So this was the open, what I was telling, the second case where already it is a open, cervix was opened, and this was, I was trying to create, bladder was dissected. So it was, there was no lateral space at all on the right side. Okay. So one side I could create a window, but on another side it was difficult, and the bleeding started. I'm just fast forwarding because of lack of time. Okay. So I tried in all the aspects of creating a lateral window on the right side, and the bleeding has started. I could not make out from where the bleeding actually. This was a round ligament pull which we were giving. So it was difficult to identify the site of bleeding. So I given a pressure with the equipment. And at the same time, the patient had some anesthesia. This thing we were not hypercarbia was also getting, and the surgeries was time was also getting prolonged. So I opened her and then completed her circulage. Okay, convert by opening, and this was her this thing why she was not getting coming out, and then ETCOT went up to 67. Then frank pulmonary edema on X-ray. On table, this thing has been done. Okay, and hypercarbia. So post-op, as I described, it was a difficult to do. Means, both the conditions were contradictory to her about relate. Considering her position also was not favorable for the baby, but it was good for, we have to give a priority to the mother. So difficulty of passing the needle is also one of the problem with patients if you could not do the proper lateral window. So this one of the case which we have put in during pregnancy at 12 to 13 weeks, she has the actually developed the IUD at 19 to 20 weeks. Okay. Then that gestational age, we have put done a colpotomy, cut open the stitch through the colpotomy and allowed her vaginal delivery. Okay, so post-operative complications are early complications.
Hello.
Of hemorrhage. Yeah, I'm just, yeah, hello. Hello. Anybody wants to, hello. So early complications like hemorrhage, infection, urinary retention, pain management, and these all things has been covered. Late complications might be uterine rupture, preterm labor, and PPROM and stitch displacement. So failure of cerclage is also one of the problem. It may be because of improper level placement, loose knot, infection, and advanced cervical shortening. Prevention is by place at internal level os. Place the suture at internal os level. It should not be too tight to strangulate, or it should not be too loose. And most of all, we need a very experienced surgeon to conduct these surgeries. So delivery and future issues, we have to, these patients lead elective LSS as 37 to 38 weeks. And if any untoward effect happens, you can go by laparoscopically and then cut the knot and then plan for the normal delivery, or you can go vaginally and then by colpotomy and cut the knot. Then this is again, actually, I don't want to go this all because it's a short of time. Actually, I take nowadays a modified procedure where I tie the knot during the interval encirclage. I tie the knot posterior to the into the POD. I don't tie the knot anteriorly. For that, I put actually this video is available on my YouTube. I mark the entry point of the needle. I go from posterior to anterior on the right side first, and then go from anterior to the posterior on the left side, and then tie the knot posteriorly, so that it will be easy during colpotomy to hold the knot and then cut it out and then take out. But you should take the care and observe the patient after taking out of the suture, whether she has got any vascular erosion and any intraoperative post suture removal bleeding in the pelvis. Okay. So this is actually a video of interval circulage. Okay, where you can take the needle and then tie the knot posteriorly. So special scenarios. If it is too big, you have to put the first trocar with a open entry, Hassan's technique, careful bladder dissection, consider pre-pregnancy. Placement will be better than during the pregnancy. Okay, and interval encerclage is a better. Then it is very difficult in obesity patients. So we have to put the place ports at a higher level. Longer the instruments we have to use for these patients, and positioning should be good. Surgeon safety, these all are the surgeon safety checklist. Don't forget about the intraoperative anesthesia care of the patients, which is also a very important part during pregnancy. And low intrauterine pressure has to be 12. And you should use a proper counseling to the patients, and you should take relatives into very much confidence, and you should explain the all possible complications before attempting the TLC in pregnancy. So these all are my key take-home messages. TLC is effective but technical demanding. Most complications are preventable. Correct anatomical level is critical. And pre-pregnancy placement gives best outcome. Surgeons' experience improves the success. With this, I would like to end my presentation. Thank you. Thank you, everyone. Thank you, ma'am, for sharing my talk session. So, Ma'am, madam. Hello. 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 Any questions? Hello. Am I audible? Hello. Hello.
Yes, madam.
Where is Dr. Soumya? Mani, madam. Hello.
Yes, madam.
So can we, Kiran, this thing, whether the president and all are there, or we'll close the
No,
session?
yeah, it's 7 o'clock, madam. Another webinar.
Yeah. So
Yeah.
we will, can we close this session now?
Yes, ma'am.
I think I just wanted a permission of chairperson. Where is Soumya, madam?
Oh, madam.
Just 1 minute.
No. She's there. She's there, ma'am.
But is it audible till now?
Yeah, ma'am. Clear.
Yes, ma'am, you are audible, ma'am.
Okay. I think there is no time for the question, but most of the things I cleared in my talk. If you have anybody has questions, you can just text me on my
Hello, Prabha.
personal number. I can discuss with them.
Hello.
Yes, ma'am. Yes, ma'am. I can
Hello,
hear
Prabha.
you.
Yeah, can you hear me? Yeah,
Yeah,
it was
ma'am. I can
wonderful,
hear
very
you.
informative. Hello, it was wonderful, very informative. I just wanted to know one thing. Suppose like patient with incompetence with bulging membrane, can we go ahead with laparoscopy?
Yes, madam. The same thing I told. My second case was bulging membrane, 2 centimeter dilated, and then I have put her transabdominal encerclage at 22 to 23 weeks, putting her
Oh, that's
membrane
nice.
inside with the Foley's balloon, and she is now
Uh-huh.
28 weeks.
Oh, that's nice.
Yeah, she is now 28 weeks.
Yeah. How many
And
cases you have seen like that?
I myself done advanced pregnancy. These things, 2 cases, ma'am.
Okay,
Advanced
okay,
pregnancies, like otherwise, like 13 weeks, 14 weeks, we have done a lot. But these
okay.
like 22 weeks, 23 weeks, I have done 2, and one has got, I think, in between, you missed the link. So there
Yeah.
discuss the rupture uterus.
Okay, okay.
Uh-huh.
Okay,
Yes,
Prabha.
ma'am.
Thank you. Thank
Yes,
you.
ma'am. Yes, ma'am. Thank you,
Thank
ma'am.
you.
Thank you
It was
for,
very nice, very informative. Keep going like this.
yes,
That's
ma'am.
nice.
Yes, ma'am.
Okay,
Yes, ma'am.
bye.
Thank you, ma'am. Thank you for
Bye.
chairing the session. Yes,
Thank
ma'am. Yes,
you.
ma'am. Yeah. Bye. We will just declare that we have completed this 10th webinar. Little bit technical hitch for that. I am extremely sorry, but I will see that next time we can do little better without technical hitch. Thank you, President Sir and Secretary Ma'am. And we will shift to next our Gyana Deepa webinar. Thank you one and all. Okay, ma'am. Curiosity.